Hey everybody, I hope your quarantines are going well. Today I will be discussing acute lymphoblastic leukemia and the clinical case of Roger Gonzalez. Acute lymphoblastic leukemia, or ALL, is a cancer of the lymphocytes, usually of B lineage. It is an uncontrolled proliferation of cancer cells which can lead to severe symptoms. Acute means severe or sharp and is exemplified by the disease's quick onset and progress. Lymphoblastic is a description of the cells, as the cancerous white blood cells are predominantly small, young leukocytes called blasts. Finally, leukemia is the general term for cancers derived from certain white blood cells. This disease is especially dangerous as the cells circulate the body, increasing opportunity for metastasis and limits direct treatment of a primary tumor. Some general info about ALL. It is the most common pediatric cancer at about 30% of all pediatric cases. There are 2,500 to 3,500 new cases annually. 70 to 80% of all cases are of the B cell lineage, which focuses on the right-hand side of that graph. It also has a very high successful cure rate at 90% cured after the first chemo induction. And it is also non-genetic in nature, as it occurs from sporadic mutation. Some of the symptoms of leukemia are fever, a high propensity for infection, bleeding, and bone pain. Other symptoms may include pallor, petechia, and purpura. Some more specific symptoms to ALL are swollen lymph nodes and an enlarged spleen due to cancer cell buildup. Some more severe complications occur when the central nervous system is introduced to the cancer, including headache, lethargy, seizures, or double vision. These symptoms are more rare, but can suggest a more dangerous form of ALL. When testing for ALL, bone marrow, blood, and cerebrospinal fluid are extracted and checked using dyes and microscopy to look for large clusters of blasts. Some of the morphological features of a typical ALL cancerous B cell are a predominant nucleus, dispersed chromatin, a large diameter with abundant cytoplasm, as their size is often much larger than their non-cancerous B cell. Along with that, the cells are covered in cell-specific antigens for their category of cell. B cells contain the CD19, and immature lymphoids contain TDT. However, more specifically, ALL cells produce CD10, leaving an opportunity for treatment open for attack. Some of the mutations that can lead to ALL are deletions, insertions, fusions, and translocations. Translocations are important for determining statistics around survival rates, as certain mutations have better or worse prognoses. Some of the favorable prognoses are hyperdiploidy, or extra copies of chromosomes, and a translocation between chromosomes 12 and 21. More unfavorable mutations are hypodiploidy, which are less chromosomes, and the Philadelphia chromosome, which is classified by a translocation between chromosomes 9 and 22. The management of ALL is a three-step process. It begins with induction, a round of broad-spectrum chemotherapy that targets the cancer cells. For 90% of patients, this round is enough to lead to clinical remission. To reduce the risk of minimal residual disease, another round of previously unused chemotherapy drugs are administered in order to make sure no more cancerous cells are present in the body. Lastly, testing and close care are provided for 2 years along with preemptive lumbar chemotherapy in case any cancer has entered the central nervous system. Roger Gonzalez presented as a 5-year-old boy with pallor, fatigue, bone pain, and bruising. Because of this, physicians sent out for a complete blood count to determine the possibility of leukemia. The blood count found that his white blood cell count was 10 times higher than average, whereas his platelet count was through the floor. This led his physicians to run karyotype staining and sent out samples for microscopy, which determined that he did not have the unfavorable T9 to 22 gene translocation. For his treatment, Roger completed his 3-step regimen and after 9 months of treatment was determined to be in complete remission. Unfortunately, 9 months after, Roger began experiencing fatigue, bruising, and fevers, which led to his hospitalization for a second treatment regimen. Although his physicians used novel chemotherapy drugs, Roger's leukemia was proving to be chemotherapy resistant. Therefore, his physicians began looking for other treatment opportunities. A previous treatment called allogenic hematopoietic stem cell transplantation was considered. This procedure would use donor stem cells to replace the leukocytes of Roger's immune system in an attempt to neutralize the cancerous B cells, known as the graft versus leukemia effect. However, this process requires that the donor and host have perfect similarities in their human leukocyte antigens, which is very rare even among family members. If these antigens do not match, the patient runs the risk of getting graft versus host disease, where the new cells of the body see each other as invaders instead of the cancerous cells. Although this method is potentially dangerous, it is still used today as it is a simple procedure. I'd recommend all listeners to go to bethematch.com and sign up for a testing kit to determine if you could help save someone's life. In the case of Roger, no donors could be found, so his physicians got him into a clinical trial for a procedure known as CAR T-cell therapy. CAR, or chimeric antigen receptor, allows for the reprogramming of healthy T cells into ALL targeting machines. The first procedure is to collect blood from the patient and isolate the T cells, preparing them for the viral vector. The second portion of this modification is modification and expansion of the T cells. In this case, a viral vector containing the coding information for CD10 and CD19 is used to infect the T cells, transplanting their genetic material into the nucleus, driving the production of the antigens. These T cells are now able to target only the ALL cells, rather than run the risk of graft versus host disease or other accidental targeting. These cells are then multiplied to increase the power of the treatment. Lastly, the cells are reintroduced into the patient, followed by close monitoring for any ill effects. A few days after receiving his modified T cells, Roger developed a fever and confusion due to the high levels of inflammatory cytokines in his bloodstream due to the increase in white blood cell activity. However, after treatment, Roger's fever broke and he began to heal. As he did, his white blood cell count rose, and modified T cells amounted for 70% of his new white blood cell count. During his treatment, Roger showed no signs of minimal residual disease or any other complications. Today, Roger remains leukemia-free. He has no B cells and has decreased immunoglobulins as his immune system was deeply damaged by the chemotherapy. Because of this, he requires monthly infusions of intravenous immunoglobulin to keep healthy, but outside of that, he is healthy and enjoys playing soccer.